Hi, everyone. So good to see you today, and welcome to the third and final webinar for the CHIME ScaleHealth Workforce Challenge. My name is Taylor McPartland. I'm the CEO of ScaleHealth. Really excited to be here with you all and excited to get into the meat of this conversation for the next 50 minutes or so. We're getting started a little bit late. We might have another speaker from LifeBridge joining us, so I'm going to keep my introduction very short. For all of you that are new to ScaleHealth, we are a health innovation marketplace and platform, and our whole goal is to work with amazing innovators, and thought leaders, and entrepreneurs that are trying to address every aspect of the health or healthcare industry. And we aim to leverage our process and our methodology to connect them with amazing health organizations, health systems, health plans, that are always looking for new innovative ways to be able to provide the best quality care to their communities, their members, and their patients that they serve. And so that's what brings us all together here. We've been fortunate enough to form an amazing partnership with a team over at CHIME, and for this particular challenge, about 10 health systems that are all dedicated and focused on addressing one of multiple aspects of the workforce, challenges within the workforce industry. Today, we're going to have a chance to hear from Tressa Springmann and her team over at LifeBridge, and hear how they think about innovation and some of their goals and going into the new year. And so with that, before we dive into the meat of that conversation, I'd like to hand the floor over to my good friend and colleague, Keith Fredenberg, the COO at CHIME.
Thanks very much, Taylor. Absolute pleasure to be here with you again, celebrating the opportunity that we have to partner on this really important challenge focused on workforce challenges out there. I'm Keith Fredenberg, Chief Innovation and Operating Officer at CHIME. If you're new to the CHIME ecosystem, we're an association of healthcare CIOs and other digital health leaders. On the provider side of that health and care ecosystem, we have roughly 5,000 total members, representing almost 37,000 facilities across 47 countries. And it's my pleasure to be able to work with great people like Tressa and LifeBridge and her team on a day-to-day basis to try and help their difficult jobs be maybe not less difficult, but a little less challenging where we can. One of the ways in which CHIME supports its members, and our members have a lot of pressures on their shoulders, there's no doubt about it. They're pressing financial concerns, they've got competitive pressures, and the weight of truly so many difficult and complex workforce challenges. I think one of the things that CHIME can do here in supporting them is just helping to identify innovators and innovative solutions out there in the ecosystem to help us improve health and care and tackle some of these really complex workforce challenges. That's where this great partnership comes in between CHIME and ScaleHealth, my great friend Taylor and everybody at ScaleHealth that does so much amazing work, and the opportunity that we have to work together. Two different but vital ecosystems coming together, and this particular challenge, again, focused on some of those critical workforce challenges. I think to the extent that we can be successful and identify some opportunities to bring some unique solutions to the forefront and help our CHIME members like Tressa and LifeBridge, it's simply a win-win. So with that, Taylor, thanks again for the opportunity to be here. Greatly appreciate the partnership with ScaleHealth, and so awesome to have LifeBridge and Tressa and her team with us. So with that, India, I'm going to turn things back over to you. We'll get started.
All right. Perfect. Thank you so much, Keith, and welcome everybody. My name's India Williams. I'm the VP of Operations here at ScaleHealth. I want to thank you all so much for being here, and a welcome back if this is the third webinar that you're participating in with us as a part of the ScaleHealth and CHIME Challenge. We're so grateful that you've chosen to spend the next hour with us. We are so excited to have this last final conversation with Tressa Springmann. She is the Senior Vice President and Chief of Innovation and Digital Officer at LifeBridge Health. We also are very excited that Tressa has brought some friends along with us. So some of her colleagues will be sharing their perspectives. So this should be a really fun, engaging conversation. You'll get to hear how multiple members of the LifeBridge team think about this workforce and staffing challenge. Before I introduce Tressa and her team, I want to go over just a few quick housekeeping items for today's conversation. As always, we want this to be a dialogue and conversation. And so as Tressa and her team are speaking, if anything resonates with you, you have any comments, questions to bring to the table, please feel free to use the chat. With whatever time that we have left as we get towards the top of the hour, I'll facilitate a little conversation with their team, and we can hopefully get many of your questions answered. So please use the chat as we're going through this conversation, and put any comments, questions there. And with that, I'm so excited to welcome Tressa and her team. Tressa, thank you so much for joining us. Just to go ahead and kick it off, do you mind maybe giving us a bit of a personal introduction so we can get to know you better? And then can you introduce us to your team and LifeBridge Health for many who may not be familiar?
Thanks, India, and good afternoon, everyone. We actually at LifeBridge Health, I would say, are a super representative health system. We're only about $2 billion in revenue. We have 5 hospitals, probably 300 physical locations, but they're all in Maryland. They're all in a very contiguous geographic area. We actually are making more money these days on an outpatient basis than on an inpatient basis. And in Maryland, we have a very unique waiver from Medicare. So we are not reimbursed for more volume. It is absolutely about value in the Maryland area. And I had to giggle because the I in my chief actually is information. I'm one of those old school CIOs and have been for about 20 years in a couple of different organizations. But I can redeem myself because I did bring along Adam Beck, who is our lead digital innovation executive. And I'd like to turn it over to Adam to introduce himself and his role briefly at LifeBridge. And then again, have the pleasure to be joined by one of the LifeBridge HR executives, given the nature of this discussion. And honestly, our desire to be very available to surface and suggest and answer any questions from these innovators and early stage organizations, not just from the IT ranks, but both from the innovation and HR perspective. So Adam?
Sure. Thanks, Tressa. That was a nice introduction to LifeBridge Health and introduction to me. I'm Director of Innovation within the IS department here at LifeBridge, and I've been part of innovation and innovation's leadership here at LifeBridge for probably close to 4 years now. We are a small team, a very small team. You know, we realize that it takes a village, right? You know, a single small group of individuals can't drive innovation across the entire organization. It's got to be driven by everybody, frontline staff to the senior executive. Here within innovation itself and the department, we kind of operate under kind of 3 programs. So one is we support internal ideation and internal innovative efforts, either using current technology that we have in-house that we're trying to leverage in an innovative fashion, or technology that's being brought in externally to our organization and we're trialing something, we're piloting something. One of the other big, huge programs that we have is a digital health accelerator that we co-manage and participate with Care First, our Blue Cross Blue Shield provider here in the state of Maryland. And then a third program, believe it or not, is we actually have a bioincubator that we have about 5,000 square feet of wet lab space that we use to support the biotech industry here in the state of Maryland. It's really cool. We've got some very, very early stage digital or medical medtech device and diagnostic companies in there cranking away on doing research and collaborating with our clinicians. Yeah, it's a quick introduction to myself. I'll turn it over to my colleague from HR here to introduce herself and get off with it. Thanks.
I'm mute.
Yeah, you're mute.
I'm Terry Carter, Vice President of HR Operations, which means I really work with all of the HR leaders and business partners and other HR staff at the hospital sites sort of the front of the house group, interfacing with managers as managers and then managers as an employee and all of our employees. We support about, I guess, 11,000. LifeBridge has a lot more affiliations and so forth, but the actual employees, it's about 11,000 employees, and recently expanded our services to now include trying to support our physicians who are, as opposed to at-will employees, instead they have employment contracts. Makes for interesting times.
Thanks, Terry.
Sure.
No, thank you, Tressa, Terry, Adam. We're so glad that you guys are here with us. Just to kick off the conversation, I think I'll start with the question. Tressa, I'd love your input, and then Adam, if you could share a bit as well. I think it's very tied to kind of your role at the organization, but just generally, how does LifeBridge think about the word innovation, right? It's a big, heavy, and sometimes scary topic. And so I'd love to just start off with that, your kind of views on what comes to your mind when you think of that word. And in particular, you know, given the state of the industry and the market as it relates to kind of recovering from the COVID-19 pandemic, you know, how has that impacted the way that you view innovation and the way that you work with startups at LifeBridge? Maybe Tessa, we'll start with you.
Yeah.
Tressa, I'm sorry. Apologies.
No, look, I've been called worse. Ask Keith. No, truly. You know, as I kind of led with, we actually are, we represent what most of American healthcare is. We are not a massive organization with very broad, deep investment funds, nor do we have this hugely funded, diverse innovation arm. I think we're just kind of the common guy out here. And so I think really Adam, he described nicely the three prongs of what the innovation team is doing and working on. And I think we really take a page from Clay Christensen saying that, you know, probably 99% of what we do that we call innovation is really learning from other industries or other areas and their own discoveries. It's more an adaptation of something great and not necessarily that bright, shiny object. You know, you asked about what have we seen since the pandemic? You know, and again, I'm sure this is a repeat comment, but as challenging as those circumstances were, we all moved through that with an expectation and an understanding that it was a burning platform moment. You know, all these external influences were starting to happen and really translating into this new era of what virtual could bring to us. We had disruptors that we were competing against because from a social distancing perspective, they were well ahead of us on the virtual journey and could offer those safety options. Combine that with an ever increasing workforce shortage that Terry and her team have been just living the last 3 years. And then now, you know, the last 12 months, I don't know about most folks out there, but we're under enormous economic pressures as inflation has increased, as these really critical workforce members are carrying a premium dollar. So honestly, it's a bit of survival of the fittest. And at LifeBridge, we're pretty tenacious, and we really believe that we're going to have to embrace innovation from within and with small tests of change so that we can adapt to what's happening from these external influences. I would really, really love, Adam, if you don't mind taking this group on kind of a deep dive on what the 1501 partnership with CareFirst is, the cohorts, the type of organizations, and maybe some examples, Adam, of a couple of those companies and what they're actually doing now with LifeBridge Health. I mean, I think that will just put a point with some good examples about the art of the possible here.
Yeah, no, I'll actually start with that theme of survival of the fittest, because about 3-4 years ago, when 1501 Health as a digital health accelerator was being conceptualized, we were getting knocks on the door all the time here at LifeBridge Health from early stage digital health companies. It was a much different environment, obviously, out there. Things were springing up all over the place. They were, and knocking on every single door within LifeBridge Health. And we were, evaluating a lot of these companies and spending a lot of time and looking at them. We're like, why did they go down this path? Don't they realize we have this EHR that we spend a considerable amount of money on, and we invest a lot of time and resources, and they do that. Why is somebody going out there and trying to recreate the wheel? We saw a lot of recreating the wheel.
Yeah.
And realized, you know what? We got to figure out a way to work with digital health companies that we think are going to make it. They just need a little bit of nurturing and guidance. And that we also think are going to make an impact to the members of our community and how we actually serve our community. And we were fortunate enough, we had really good ties with Care First, who had the exact same thing happening on the payer side. And they said, let's combine efforts. Let's build a digital health accelerator partnered between a provider and a payer. And we could bring these companies in that we think they're going to improve patient experience, patient service, access, and reduce cost and improve quality. Let's figure out a way that we could support these together and figure this thing out and really provide guidance to these companies from both a payer and a provider perspective. And that's what we ended up putting together. We called it 1501 Health. That's because a lot of the good names are already taken. So we went with the address of where we were setting this thing up. Now we set up a co-working space, small. We kept everything really small. We didn't go huge bang, and we didn't dump it. We didn't create a big, huge fund anywhere. We went at it to say, let's keep this relatively small at this point. But then obviously COVID came in and impacted the way we're kind of putting things together. But we still manage out of the gate every year to support 5 to 8 companies through this program. It's a 1-year-long program. We started off with 5 companies, we went to 7 companies, and then this is our 3rd year of the program at this point. And in total, we'll have 20 companies that have gone through the program. What we do is we get anywhere between 125 to 150 applications each year. We evaluate those companies together. We look for how well do they fit our organizations and the needs of our community. That was a big thing that we set forth on. And then once we accept those individual companies, we set them up with advisors from each side to help them advise them on their strategy and their efforts. And we look for opportunities to trial those solutions and bring them in and further pressure test that solution and further guide what they're working on. And then finally, we make sure we have a little bit of skin in the game on both sides. So Care First and LifeBridge combined each invest anywhere between $50,000 and $65,000 in each company through a safe note, very similar to a Y Combinator type arrangement. So we've had some really good success. I'll give you one example. First cohort company, we had a company called LifeBridge Health, and they were one of the cohort companies, and their effort was really to work with the African American community to improve the health of the community, and using the barbershops and hair salons out there as a channel to reach out and engage the African American community and provide them access to health services. We actually we piloted their solution. We had really good success. The big thing comes down to exactly how does this get paid for, and who will ultimately be the purchaser of their particular solution.
Sure.
And so through the efforts and through our work with them and their and Care First guidance, they realize their ultimate customer will be a payer. And so they are actually doing a lot of work with Care First right now. And to a degree, LifeBridge Health is benefiting from the work that they're doing in our community and connecting individual members of our community with primary care physicians and ensuring they use our ED resources to a lower degree. We've got another pilot ongoing with a company that is working to reduce the digital health literacy gap with our older population and providing resources and assisting those patients to onboard on some of our engagement tools here at LifeBridge Health. And then we're exploring an opportunity for one of the companies, the current companies right now, on care management solutions to better connect our community members with resources out in the community to reduce overall utilization and potentially even reduce length of stay if they do get admitted to our hospital. So a lot of good stuff. Yeah, it's been a tremendous ride because we rode this all the way through COVID. That was a challenge. And then of course the investment market has changed. The venture capital market has changed considerably. It was also changed some of the dynamic there as well. So it's been interesting. A lot of good lessons learned. I can talk forever, so I'll stop there and we can go from here. But
hey, Adam, I know one of the things India wanted to make sure we spoke to is what are kind of our minimal expectations before engaging with an early stage company. And I can speak to it from a security risk assessment, et cetera. But especially with our 1501 health companies, I think it's been an eye opener on kind of the expected stakes in the game that they ought to have in place before they engage in a kind of contractual conversation with a health system. Can you speak to that a little?
Yeah, I mean, they're obviously your key components. They got to make sure, right? So it's obviously it's got to pass IS security review. That's a big one.
Good. How are you?
And then compliance has to weigh in too. They got to make sure there's nothing from a compliance or risk standpoint that would get us in trouble. But from a risk standpoint, we have to take into account, like, if we do a trial, we do a pilot with a company, what happens if it doesn't work, right? What happens if they go under? The company goes under. Where does that leave us? Or what happens if we decide to back out? So we got to make sure there's kind of a defined endpoint, just in case. So we just are ensuring to say, okay, we'll pick up the slack here. It's not going to impact us in a significant fashion if things don't really work out. So we really got to make sure that we have that squared off. And I think another thing, which is really, really critical here, we got to take a good hard look at our own canvas and make sure there's white space. Or if there's not white space, there's paint somewhere that we're willing to paint over with the solution. And if it's not there, you can forget about it. It's not gonna get success anywhere. And then obviously another big, huge one, having key executive champions behind this on any initiative, and then clinical champions where clinical component is needed is really huge.
That's fantastic, Adam. No, thank you for first the examples on how you're already interacting with innovators through the 1501 health program. That's really helpful to kind of ground this conversation in some tangible references, and then just some information on your minimal expectations is great. Just to talk about that a little bit further, and a question that always gets asked in the chat, so maybe I'll just kind of front load it here to get perspective is, when we're thinking about some of those minimal expectations, another piece of that is understanding the current tools and systems and platforms that you guys use, and how our innovators can be thinking in advance about implementation. And so is there anything that specifically comes to your mind there around just, particular EHR platforms or things that you guys are currently utilizing that they need to be able to find fit within your current workflows and systems so that it's a, meaningful partnership on both sides?
Yeah, I'll start off with this, but you guys get started because I'll keep this in the HR space. It was a very good example. So you got to watch one is you got to make sure you have an ROI of some sort. Can't really be a nice to have. So be real careful there. Please go out and reach out to clients before you start spending a lot of money and doing a lot of programming. Very recently, as early as last Friday, I spoke to a company that said, hey, we want to create a solution that would connect glucometers to their providers and allow the providers to have access to the glucometer data. Well, there's 50 million of those out there. I'm like, well, hold, please stop. Think about what kind of crowded space there is out there. And then, but try to make sure, reach out to folks and understand not just what they have right now in place, understand maybe what they might have 2 or 3 years down from now that might end up providing the solution that you're looking to.
Yeah.
So we used to have a considerably older version of Kronos, and it was not the prettiest thing in the world. And it was tough to learn, but it worked. But we now have UKG, which is a really slick tool and opens up the door to do a lot of stuff with. So if you are going out and trying to create a solution to tackle this problems folks were having using that old version of Kronos, that's not going to be here 3 years from now, right? As everybody switches over. So just really understanding that ecosystem of where things are shifting to and watching out what that canvas is going to look like 3 years from now is really critical.
I'd also hop in and say, everyone is always trying to, chase that one big thing. But I know in our experience, and hopefully now that you're here, Tara, we'll give you a chance to talk, but a lot of the day-to-day in larger organizations is kind of a death by paper cut. It really, the things I get excited most about, obviously AI, but aside from that, it's really fixing a lot of the littles, because when the littles are a barrier to care, to productivity, to a happy day, to engagement, it all of a sudden becomes a really big problem, and one that many individuals aren't going after. So again, what we really get excited about is someone who's just targeting one of the littles, but one of the littles, it happens a lot.
Absolutely. And let's talk about that a little bit more, Tressa. So I'm actually going to put into the chat, as we always do, the three categories that are specifically related to this joint workforce challenge. And so I'm going to drop those in there for everybody now to see. So our three categories for this challenge are staffing precision, oh my gosh, that's a tough word today. Staffing, precision and planning, workforce engagement and retention, and AI-enabled productivity and performance tools. So Tressa, you already touched a little bit on the AI piece. Maybe we'll start there, get your thoughts, and then I would love to hear, Terry, your perspective as it comes to workforce engagement and retention.
All right, thanks. And I'll be brief because, I know that not very often do folks in this specific startup, and in fact, even Terry is gracious. She's like, what is this digital innovation? Why do you want to talk to HR? But that's just the amazing thing about CHIME and ScaleHealth and this group here, that this is what's upon us, a real constraint around our workforce for a variety of reasons. But I'm very, very excited. Look, we've had robotic process automation around, particularly in back office functions, and we need to do more and we need to do better. But the theme is the same on the early stage RPA all the way up through the really sophisticated machine learning and large language models. Perhaps this has an opportunity to bring joy back to medicine, but the intent here is, and we've been talking a lot internally about human in the loop or augmentation. If we are thoughtful and we appropriately balance the innovation with the risk of what is upon us with artificial intelligence, it ought to allow our workforce to be performing in a manner in which they're having more of a direct impact on outcome as opposed to doing the busy work. It really has the ability to be a productivity partner to any given individual as we go through our day. For years, we've had the benefit. One of our organizations is of Jewish tradition. I have a team in Israel, and we provide remote stroke, remote social work. We have robotics that support our intensivists, not just EICU, but literal robots that allow our intensivists to be at any one of our entities or all at the same time. There's so much hype around this, but there's always and also so much excitement. If I would say to anyone, if you've not, and sorry, this is not a pitch of Peter Lee, but I'm reading The AI Revolution in Medicine, GPT-4 and Beyond, and just reading it excites me, because if we're able to capture the value with making sure that we don't lose trust and that we're being transparent about how these tools are being applied, there's just tremendous excitement. Look, I'm sure you've heard a lot from others about virtual nursing, Moxie, what we need to do for governance, ambient. So I won't bore the team here. I guess what I would say is this is going to be an explosive area. And for the next little while there's norming and forming, for those who do have the appetite for being early in, but understanding it's going to be a very busy pond, there is tremendous opportunity given our workforce challenges specific to enhancing our performance and the productivity of folks in the healthcare space. Anyway, I think I may have let my excitement get ahead of me, but let me turn it over to Terry to give perhaps a little bit more grounded response around workforce engagement and retention. Terry?
All right, I'll give it a shot. I'm not sure if I'm going to say anything that translates to something actionable. I'll just go ahead and sort of lay out the big challenge. There's two areas. Just from a systems perspective, we've got a lot of different systems that don't necessarily work well together, but we're getting there. Our partnership really with IS is probably the strongest partnership we have internally within our organization, because we're constantly, we have modules we haven't turned on yet. But to do so, the effect of doing that, it's pretty monumental. But I do feel like in the next 2 years, there's going to be a lot of efficiencies that we will have achieved. Those things will occur, I have no doubt, as far as better system integration and less busy work. I would say the biggest challenge I believe that HR has is, one, not enough people in the city to perform the work that we need done.
Yep.
I struggle with the actual business model of practicing healthcare in the state of Maryland, because I come from, you're always vying for, let's get that top surgeon in so we can build our volumes up so we can make some more money. And it's taken me, like, I've been here 4 years, and for 2 years I was drooling. What? We don't get paid for our patients? And it's a problem. But the thing is, if we don't have good systems, if we don't have good practices in place, like the stuff that Tressa is focusing on, the workforce productivity stuff, you got to have good processes in place so you can get the patients in and get them out as quickly as possible, or better yet, don't even have them come to the hospital in the first place. Some of them shouldn't be there, so that when you have a limited workforce to do the work, you don't need to be seeing patients that shouldn't be in a hospital. So that's why I'm very happy about the work that it's being done on productivity. But at the core of all of this is people are not very happy these days.
Sure.
And it's really a burden on the workforce. There is so much anger and unhappiness that is demonstrated daily by our workforce, how they interact with one another. It's like, and I'm putting myself in there, so I'm not holding myself above. There is a level, there's a chip on everybody's shoulders that is generating an extraordinary amount of work for HR. People fighting, people having their feelings hurt, people feeling misunderstood or misrepresented. And it's an energy suck like you would not believe.
Yeah.
And
Can I hop in on that, Terry? Because we are not alone. These are really common discussion topics. And, to Terry's point, actually, we were with Taylor and I think John Mark and Keith at another innovation conversation.
Yeah.
And it wasn't 10 minutes before the idea of workplace violence came up, and just the horrific situation with healthcare workers, and that they day in, day out are actually, we're looking at elopement tools, violence tools, educational tools, visitor management tools. So as it relates to engagement, violence and safety, sadly, is another outcome of what has happened. And it's not just in the inner city, it's in all of our entities. But when we talk about workforce engagement and retention, this desire when they come into work to have that acknowledgement that we are doing everything possible to keep them safe and to keep them engaged. I mean, one of the things that I'm working with Terry and Lisa and her team on is most of us here are knowledge workers, right? We use computers. We are interacting usually via Zoom or through email. That is not most of healthcare. If you're in a practice, physical therapy site, surgery center, inpatient unit, we have such a hard time communicating. These are individuals that we cannot require to use their own personal devices necessarily. But think about, how do you get engagement and cultural alignment when the majority of your workforce isn't at a computer, isn't going to, and don't read emails, and that's not what they come to work for. So it's tough, and it's gotten tougher. And as you can hear from Terry, it's got some really, really complicating factors that a lot of people aren't talking about, but until we talk about them, they will go unsolved.
I'll actually chime in a little something here too, because I've been monitoring a little bit the chat here, because somebody asked, what is a top priority or top issue? And when I think about some of the tools that people are kind of creating, hey, can I get more precise staffing? My concern on all of this is an AI algorithm might come in and say, hey, based on the acuity in your hospital, you need a staff of, let's say, 150, just hypothetically thrown out there. We're in the situation right now is saying we're doing even better than that efficiently because we only have 140. And we're scrambling to find even the 10. Or even if we were to take it down to 150, whatever it means, we're scrambling to even find that right now. Because we're post-COVID, man, the community hit us really hard. We have patients that are coming in with really significant S2H issues. And they're kind of being left here, and we're stuck holding the bag, the hospitals are. And, over the weekends, discharges come to a halt. The downstream facilities that we need to get these people, because we can't send them home, whether it's to assisted living facility or a SNF or whatever, they're not accepting patients over the weekend. That's rough. So I almost wish, let's make sure those sites and those areas and those institutions and organizations are operating as efficiently as possible and to their best possible. Because if they are, then we should be able to get our patients out quicker, reducing the amount of patients we have in the house to begin with. And then we've got the right staff, and then we can actually get more precise. So I think there's a lot of opportunity in that area, even worse than the hospital. My fear right now with the hospitals right now, it doesn't matter what an AI is, because we're scrambling to even get the bare minimum at this point.
Right.
Oh, Indy, I don't know if that was the
No,
you got us going, a little bit provocative here. So I'm going to hand it back to you, and you can redirect us with the time or with what's in chat. We could go on forever.
no,
I still want to say something else though on totally everything that's been said is spot on. I think that the world, there's a cultural, we are in a culturally sort of, I don't know if the word is malaise or disease, because there is a pervasive sense of entitlement being communicated by every person. Every morning they wake up and they're told your voice matters. We're hearing this. Everything you feel is valid. Everything must be, and you must have your feelings acknowledged and attended to. It is creating, I really do think part of the whole, it's not achievable for any one person or any organization to possibly meet the needs of 11,000 individual people. And the term I'm going to say that is missing in all of this and I'm stealing it from what somebody else said recently, is there is no grace being demonstrated between people. The need for grace, or the acknowledgement that all things can't be solved for all people every time. There is, it is, and I mean, it's affecting how physicians are perceived by the patients they see, but I'm talking about from an employee standpoint. We have physicians that are being called out daily by employees and vice versa, because people don't like how they're being spoken to. I'm not saying there isn't room for improvement for the way people are being spoken to, but it's almost, there is this element of, it's getting worse daily. It is getting it's kind of the culturally in America, oh, we're all supposed to be respected and heard and heard and heard and heard, but nobody knows how to do it. If there is some magic system, people feel like because they don't feel heard, their anger gets worse. And then they're sending emails to like, my paycheck was wrong today. I get it needs to be fixed, but they don't really, they have tools to take care of it. We really do have tools for employees to really help themselves, but instead of availing themselves of it, they write to the president of the system or to a board member. And I'm not complaining about them. I'm saying this is a pervasive problem throughout, not just LifeBridge Health. It's happening everywhere, and it's affecting engagement. It's affecting because there's no grace. And
So
I don't know if there's
it's
an
interesting
innovation.
because I think it's Raphael posted in the chat, what does the workforce need? What would make them happier? And, we don't have the answer. We hope you're hearing the message, because I think there's some creative minds out there that could help all of us, based on what Terry has said, to be reminded of this very, very tall challenge of perhaps cutting people a break, giving each other grace, trying to balance this empowerment with a reasonableness of interacting with everyone. So, again, India, I'll turn it back to you.
No, this has been fantastic. I just want to thank the three of you for having this, raw, honest conversation. These are the types of things that, as a community, as an ecosystem, an industry, like we need to be talking about this more. And so, thank you for, giving your perspective on how, LifeBridge has been uniquely or, impacted by this whole space. And we'll kind of close things off in a minute. I think it was great. We were able to answer quite a few of the questions as a part of this dialogue. I also want to make a call out to what you just referenced to, Tressa, around, well, what do people need to be happier? What are the answers to these big problems? And just to say on the side, I've been getting a lot of direct messages from some of our innovators on the call who are excited by these types of conversations. And these are the problems they're really trying to tackle and solve as a part of this challenge. And so we're very hopeful that you get to evaluate and view some innovation through this process that will solve some of those direct needs that you just referenced. To close it out before I pass it back over to Taylor with our final announcements, I would love to just hear from the LifeBridge team if you have any words of advice or, just final comments for participating startups as a part of this process.
Yeah, Adam, why don't we start with you and then Terry, and I'll try to think of something creative.
I think, just be willing to be a partner.
Yeah.
With health systems as you build your solution and figure out where, how to create that partnership. Be careful to, if you're early stage, be careful to approach and just straight up ask for a contract and an annual contract or 3-year contract or whatever else. Make sure, if you're at that stage, you got to have really strong ROI, and it's going to be proven ROI somewhere. But if you haven't got that at this point, be open, and health systems will be open too. To say, hey, let's partner together and let's figure out how we can kind of come together and create a solution that will actually work well, not for us, but also work well in the industry, something you could take out to market. So be open to partnerships. That's my big important advice.
Terry?
I would echo that. I think I saw some of the chats that were popping up. Have y'all done this or this? I think be open, seek information, because we touched on it earlier. There are a lot of things that are in play right now, which in the 6 months from now, a year from now, will have solved a couple of key problems, and then another. We're constantly working with a plan to address certain aspects, and we know it will make it a better working environment. I'm open to, if somebody wants to call and ask, have y'all tried this or this, and we'll listen, and we'll probably often say, yeah, we're actually doing that, or we're actually doing this. We really do have a lot of things in play, but that doesn't mean there isn't some great idea out there that just never occurred to anybody. So,
And I thought you were going to say grace.
yeah.
Right.
I guess, I would be just remiss. I'm just going to reiterate something that I said prior, which is the things that impact us the most that need to be fixed are a lot of littles that day in, day out take away the joy of what needs to be done. So there may be one or two really big things, but I would encourage you to really latch on to one of those littles that, when it's been an impediment to success of someone in our setting 10 times a day, 20 times a week, solving for those are really, truly the innovation that will bring joy back to the workplace.
Yeah.
Well, thank you so much, Tressa, Adam, Terry, for your thoughts and perspective. We appreciate you spending time to kind of share your thoughts with our innovators this morning. And with that, I will go ahead and turn it back over to you, Taylor, with our final announcements before we go ahead and wrap up.
Great. Well, one of my goals when I think about these challenges is really looking for ways to, one, provide insight and access for our health system partners to really see what is out there from a potential solution standpoint, and really kind of think big and think outside of the box, and look at all these amazing innovators and solutions going through this process, and really be able to realize what might be possible from an operational standpoint, from a grace standpoint, from the future, from the standard of the future of healthcare. So that's really exciting to see. And then on the flip side of it, for me, it's providing an opportunity for all of the entrepreneurs and innovators on this call to hear from Terry, from Adam, from Tressa, what's keeping them up at night, and how they like to think about what an ideal future state for this industry might look like, and how it might look a little bit different for all three of them. So I just want to again thank all three of them, Tressa, Terry, Adam. Thank you for your time, for joining. I think having the three of you here together and providing each of your unique expertises to this space was really, really impactful. So thank you for that. I'm going to hand it over very quickly back to our partners over at CHIME, John, Mark, and Keith, and see if they have any final thoughts.
Thanks very much, Taylor. This has been a fantastic program. And Keith, did you want to wrap us up? I just wanted to share really quickly in the chat, if you haven't got a chance to see it, the link to our last patient engagement challenge is there, if you'd like to take a look at that. And thank you so much for your time today. This has been a fantastic series. Learned a lot. I really appreciate all your comments, Tressa and Terry and Adam.
Thanks very much, Mark. Just a final thank you, Taylor, for the partnership to be able to offer these challenges with ScaleHealth partnership, trying to do some good in healthcare. Our amazing leaders from LifeBridge Health, thank you for joining us today, and really, I think, rolling up the sleeves and getting at the core of some of these challenges. There's a lot going on here. None of these workforce issues are easy to solve. but it's only by having great leaders at LifeBridge Health and others coming and engaging in this particular challenge format that we're going to find real opportunities to solve some of these big issues.
Absolutely. India just put into the chat the link to be able to, for all of you to be able to either join the challenge or continue through the process of completing this workforce challenge. We have about 2 weeks left. So if you haven't started the process yet, please go ahead and take this opportunity to get started and provide your vision for what the future of healthcare workforce might look like. On another hand, if you have already started it and you haven't completed it yet, please make sure you complete all of the assessment criteria so that we can provide the best final report back to Tressa, to LifeBridge, and to all 10 participating health systems. We want to make sure that all of you have the chance to put your best foot forward. And so please go through all of the assessment process. And again, if you have any questions, feel free to email me. I'm Taylor at ScaleHealth. We also have India at scalehealth.com. We are certainly here to help you. And as a final plug, if you happen to be at the health conference next week, we will be there. Please join us at the Scale Health Pavilion. And we're also going to be having we're going to have a Scale Health stage there, and featured on that stage, we're going to be talking quite a bit about this challenge. We're going to be hearing from Adam. We're going to be hearing from Keith, and we'd love to see you there. So thank you all so much for joining us today. Please have a great afternoon, and hope to see you next week.
Thanks for having us.
Bye.
Thank you.
you.